Hello everyone, welcome to Med Decoded by Dr. Abu. Today we are going to talk about a syndrome uh, continuing with the series, that is the Gitelman syndrome. ठीक है. So now as हमने देखा Fanconi syndrome में जहाँ पे defect था proximal convoluted tubule में. So in Gitelman syndrome the defect is in the distal convoluted tubule. Now proximal convoluted tubule was involved in 65 absorption of 65% of almost everything. जो DCT है that is primarily involved in sodium and chloride reabsorption, right? So Gitelman syndrome में क्या होता है कि जो defect होता है, the defect is in the sodium chloride co-transporter in the DCT. What happens now? Now remember, even if a single transporter is functioning, the disease manifestation is usually not severe, है ना? So it is usually an autosomal recessive disorder. जितने भी enzymatic disorders, transporter disorders होते हैं, they need to be autosomal recessive in order to manifest, usually. Now, what happens as your sodium and chloride is not being reabsorbed, sodium and chloride का loss हो जाएगा distal convoluted tubule में. Once you have a loss of sodium and chloride in the distal convoluted tubule, that will be interpreted by body as salt wasting. Okay. So the compensatory mechanisms will kick up and that will lead to increase in the RAS system. That is your renin-angiotensinogen aldosterone system. Now, once your RAS is activated, you'll have increased aldosterone. Once you'll have increased aldosterone, that will lead to salt and water reabsorption, right? But problem is that this reabsorption fails. It is not to the level in order के जो सोडियम है उसको normal serum level तक reach करने के लिए. But once you have an increased aldosterone, you will have a loss of potassium. That is why you have a hypokalemia, right? So as you can see, you have a salt wasting. That is, you have decreased sodium, you have decreased chloride. Again, you have decreased potassium because of increase in the renin-angiotensinogen aldosterone system. You have decreased magnesium and you have increased calcium, right? We know that loop loses calcium, thiazide preserves calcium, right? So the exact phenotype of the disease is similar to thiazide diuretics. Now always remember, you can have loss of sodium and chloride, but usually what happens is majority of the chunk is being absorbed in the thick ascending limb of loop of Henle. So here the patient will have salt wasting. The patient can present with hypotension, but it is usually not severe. So the blood pressure is borderline low. Right? You cannot have frank hypotension. Usually it is borderline low. Now, as we go on with the effects, quickly revising. First is metabolic alkalosis. Why it happens? Because of increase in renin-angiotensinogen aldosterone system. Hypokalemia, again why it happens? Because of RAS. Hypomagnesemia is due to primarily a sodium chloride symporter defect, right? Hypocalciuria, right? In urine, the calcium is reduced, but in serum, the calcium might be increased, right? So this is what is talking about serum. Yeah. And you can have a severe hypomagnesemia. Now, this severe hypomagnesemia can lead to refractory hypokalemia. Okay, so your potassium will not be corrected unless and until you correct the magnesium. So these are the effects of Gitelman syndrome.